Okay, just to do a punctoplasty and express the material, is it really required to go for a canaliculotomy?
Punctoplasty. Actually, if the horizontal canaliculus has a lot of collections, I don't think punctoplasty alone will help. You have to make a nick.
Like an extended punctoplasty to the canaliculi?
You
No.
mean
Yeah,
directly
like
cut into that?
Yeah.
Then
do the 3-snip and kind of.
Will it compromise the capillary action of the puncta if both the canaliculus and punctum both are cut?
All right.
I have not done that.
Okay, yeah. That is what I do. I don't do a canaliculotomy.
Okay.
Yeah, a punctoplasty and widen it, and then express, like with a cotton bud, express it. Yeah.
Do you use any curettage or something?
No, I just press it because I don't want to injure the mucosa of the canaliculi. So that's the logic behind it. So with a cotton bud tip, just express it through the puncta, not a separate canaliculotomy.
Okay.
Yeah, I mean everyone has a different way of doing things.
I have heard somebody injecting antibiotic ointment into the horizontal canaliculus.
No, I don't do that at all.
I also have not done.
Right. Yeah. Sorry for the technical glitch. So I'm basically going to talk about, it's a video. You can all sit and relax. I'm not going to speak here. There is a voiceover. So these are my affiliations, and my affiliations in Kerala is Malabar Cancer Center in Kannur and Amardeep Eye Care in Trivandrum and Kollam. So it's about, we all know that we have benign ocular surface tumors and malignant ocular surface tumors. Benign ocular surface tumor, we all know how to deal with it, and it's straightforward. It's excision biopsy and closure of the conjunctiva. So I'm basically stressing on OSSN, which I think it's very important. There are many simulating lesions of OSSN and how to manage it. It's a video-based format. There is audio. You can just sit and relax. I'm not going to speak. The voiceover is there.
Ocular surface squamous neoplasia, or OSSN, is an umbrella term which describes a spectrum of benign, pre-malignant and malignant epithelial lesions of conjunctiva and cornea. It encompasses squamous epithelial lesions of ocular surface ranging from mild dysplasia to carcinoma in situ and squamous cell carcinoma. OSSN is the most common non-pigmented tumor of the ocular surface. Carcinoma in situ accounts for 39% of all pre-malignant and malignant lesions of conjunctiva and 4% of all conjunctival lesions. Being the most common ocular surface tumor, OSSN, or anything that simulates the condition, are commonly encountered by all practicing ophthalmologists. Recurrent lesions tend to be more advanced and aggressive, but this can be reduced to less than 3% with appropriate management protocols. Hence, it is important that it's not overlooked, misdiagnosed, or mismanaged by the treating ophthalmologists. It is postulated to arise from the limbus extending to conjunctiva and cornea from the transition zone. UVB ray exposure is one of the most important causes of the pathogenesis. OSSN most commonly presents as unilateral limbal lesion in the interpalpebral area. Bilateral presentation is most commonly seen with systemic association such as xeroderma pigmentosum and immunocompromised patients. The conjunctival lesions can have varied appearances such as nodular, papillary, gelatinous, leukoplakic, pigmented, and even rarely diffuse variants. Corneal OSSN and corneal extension of conjunctival OSSN can be seen as a subtle wavy, advancing gray, superficial, convex corneal opacity, which is avascular or may have fine blood vessels. The characteristic features of OSSN include surface keratin, positive staining with rose Bengal stain, intrinsic vascularity, dilated feeder vessels. While presence of keratin is a characteristic sign, it is also important to know the aggressive variants like mucoepidermoid carcinoma that may have less of keratin and appears more nodular fixed lesions. Certain lesions that are seen in practice that can simulate an OSSN includes pterygium, actinic keratosis, squamous papilloma, pyogenic granuloma, conjunctival lymphoma, melanoma, and rarely allergic keratoconjunctivitis. Histopathology helps in the definitive diagnosis. Clinically, it is difficult to distinguish the spectrum of histopathological subtypes. Meticulous clinical examination and protocol-based management plays the key role in appropriate management. Every case should be thoroughly clinically documented to assist in the management. Although OSSN is a clinical diagnosis, imaging with anterior segment optical coherence tomography and ultrasound biomicroscopy provides valuable information in assisting in the management. For deciding the appropriate management technique, it is important to classify the lesions into localized, diffuse, or extensive or invasive OSSN. Management options in the armamentarium for the treating ocular oncologist includes primarily surgical excision with margin-free clearance and topical or intralesional chemotherapeutic agents. Others are radiotherapy that includes plaque brachytherapy, external beam stereotactic radiation, extended enucleation, or exentration according to clinical scenario. Surgical excision with no-touch technique is the standard of care.
This is a 4 mm margin that we delineate with the bipolar cautery. Cryotherapy is the most important step. It's a double freeze thaw. We go twice the margins. That's an AMG with a glue.
The excise sample must be sent for histopathological evaluation with appropriate orientation on a Whatman filter paper, wherein curling of the margins should be avoided. The report must include a comment on the margin and base of the excise specimen, whether free of tumor or showing positivity, so that correct protocols can be followed for further management after excision. Topical or local intralesional injection of antineoplastic agents is a very useful treatment option. Interferon alpha-2b is currently the most accepted and well tolerated with negligible local side effects. Systemic side effects include flu-like symptoms, and this is usually seen with intralesional injection. It is used as a primary immunotherapy or as immune reduction to reduce the size of the tumor, and also as immunomodulation in high-risk cases to avoid recurrence. Fluorouracil compounded as 1% solution can also be used topically 4 times a day for 2 weeks, followed by 2 weeks treatment-free interval that comprises of 1 cycle. Mitomycin C is yet another chemotherapeutic agent used for OSSN. Plaque brachytherapy is used to control gross or microscopic residual tumors. Clinical scenarios where plaque brachytherapy is helpful include cases of base positivity after excision. In advanced ocular surface squamous cell carcinoma with orbital extension, chemoradiation is yet another option. For intraocular extension, options for management includes extended enucleation. For cases with orbital extension, exentration is the treatment of choice. It is possible to provide good cosmetic rehabilitation in such cases. So with this, we would like to convey a strong message that it is important to know everything about a common conjunctival tumor that you may possibly see in your day-to-day practice, that is OSSN, or anything that simulates an OSSN. Knowing what to do and what not to do is so very important for accurate management and better outcome in terms of reducing recurrence and avoiding regional and systemic metastasis.
Yeah, this is like just another one on plaque brachytherapy. This was a patient with a large tumor over here. You can see there is a scleral fixity. And this is post-brachytherapy 3 months. So I'll just show you how we do a plaque brachytherapy. This is done in Malabar Cancer Center, Telcheri, Kerala. We have the plaque there. Yeah. So basically, wherever the lesion is, the base, the pathologist will be telling you that there is a base positivity there. And this is a ruthenium plaque where there's an ethibond suture. So wherever you mark the surface, and then it's very simple. The procedure is so simple. It's hardly, a 5 minutes job for an ocular oncology person. And depending upon the dose, you keep it for 1 day or 24 hours to almost 36 hours. And so that's how simple plaque brachytherapy is. Yeah, thank you. And I'm sure many of you are, attending the International Society of Ocular Oncology. It's a biennial conference. It's happening from 3rd to 7th of this December. I'm going back there directly from here. Thank you so much. Thanks for your patient listening. Yeah.
Thank you, ma'am, for such a beautiful video presentation and
Thank you.
coming here when ISSO is so near in the brain. Thank you so much.
It's a pleasure, yeah. I can take questions if